A very warm good morning to all. Today's presentation is on the topic endodontic mishaps. Here are the contents, among which we will deal with introduction, definition, classification, access related mishaps, instrumentation related mishaps, obturation related mishaps, and miscellaneous mishaps. All of these we will cover in the coming slides. Now, first of all, as we are discussing endodontic mishaps, first of all, what are endodontic mishaps? These are procedural accidents that often occur during endodontic therapies and they affect the prognosis of the treatment. And there is adequate knowledge of etiological factors involved in these mishaps is mandatory for their prevention. Here is the definition. According to Engel, these are unfortunate occurrences that happen during treatment, some owing to inattention to the details, others are totally unpredictable. And according to Walton and Torabinazad, these endodontic mishaps are unwanted or unforeseen circumstances during root canal therapy that can affect the prognosis of the tooth. Moving on to the classification. According to Walton and Torabinazad, endodontic mishaps are divided into four types. First one is the procedural accidents, then mishaps occurring due to cleaning and shaping, mishaps during obturation, and mishaps during post-space preparation. During procedural accidents, it can happen because of ledge formation, creating an artificial canal if they do not have knowledge about the anatomy, root perforations, accidents during cleaning and shaping. It can be a separated instrument and there can be so many other accidents also. We will cover with all of these in the coming slides. And accidents during obturation, we can see a radiographic image also in the right hand side that shows a overfilled canal. Okay, there can be underfilling of the canal, there can be overfilling of the canal, there can be vertical root fractures also during obturation. Accidents also occur during post-space preparation. Now, according to Engel, it is again classified into four types: access-related mishaps, instrumentation-related mishaps, obturation-related mishaps, and miscellaneous mishaps. This one is more accepted and more commonly present classification among the clinicians, and the causes of these mishaps are differently placed here. According to access related mishaps, it can happen during the treatment of the tooth if we choose a wrong tooth, or it can be a missed canal, it can be damage to the existing restoration, excess cavity perforation can occur, there can be a crown fracture also. And during instrumentation, it can happen during ledge formation, there can be a perforation in the canal, there can be a separated instrument, there can be foreign objects, there can be a canal blockage due to improper cleaning and shaping. Obturation related mishaps can occur where there can be over or under extruded root canal fillings. There can be a nerve parasthesia also, which is a very serious element. There can be a vertical root fractures. Vertical root fractures generally have a poor prognosis and the tooth goes for extraction if you do vertical root fracture during obturation. And it can be miscellaneous also, like post-space perforations, irrigant related mishaps, irrigant getting pushed out of the canal, tissue emphysema, instrument aspiration, all of these can occur. Now let's discuss first access related mishaps. Access related mishaps can occur by treating the wrong tooth. Treating the wrong tooth can happen if there is a misdiagnosis of the tooth, there is inattention to the details, you did not recognize properly the symptoms of the tooth, and it can be corrected by appropriate treatment of both the teeth, because the tooth that does not have any problem but you have already involved it, then you have to treat the tooth. And the one that is incorrectly opened has to be corrected. One very good way of prevention of treatment of a wrong tooth is marking the tooth to be treated with a pen before isolating with the rubber dam. Usually what happens is during rubber dam placement, the tooth is covered and we generally land up in the wrong tooth that does not have any problem. So proper examination is a must. Another access related mishaps can be because of a missed canal. Missed canal can be caused due to failure to externalize the internal anatomy. What does it mean? It means that if we focus on the anatomy of the tooth, then we can see how many canals can it have. And you have to have proper knowledge about the number of canals that are usually present and the accessory canals that can be present in a specific tooth. Also, incomplete deroofing or improper access can lead to missed canals. There is generally incomplete removal and shaping of the lateral walls of the pulp chamber. This can also lead to missed canals. Now, how can we recognize a missed canal? It can be recognized by champagne bubble test. It can be by use of dyes such as methylene blue, use of ultrasonics, accurate access cavity preparation, use of magnifying glasses or endodontic microscopes is a gold label for the recognition of missed canals, and taking radiographs, that is a must. What is a champagne bubble test? Champagne bubble test is when you are placing some amount of hypochlorite into the canals, into the access cavity. When there is any canal, there would be bubble formation. The effervescence would cause the bubble formation, and wherever there is bubbling, you can see that there is a chance of a missed canal. You have to look at it. Prevention of the missed canals can be, as discussed before, it can be by knowledge of the usual anatomy. The good periapical radiographs preoperatively should be shooted. Multiple radiographs should be taken in various angulations. Then DG16 Explorer or size 6, 8 or 10K file instrument is used to locate the orifices. Usually they are very small and they have to be diagnosed properly. Then one more accumulated mishaps can be damage to the existing restoration. Damage to the existing restoration can occur by overzealous preparation of the access cavity. It can happen. The crown may chip off even with the most careful approach. And when we are placing the rubber dam clamp on the margins, if we are not placing it properly, it can damage the restoration also. Its correction can be by replacement of the restoration or by bonding the composite resin to the crown, and it can be prevented by focusing on where we are working and avoiding placing the clamps directly on the margin. Removing the permanently cemented crowns before treatment is also an option. Then access cavity perforations can also occur. These are undesirable communications between the pulp space and the external tooth surface, and these occur either peripherally or through the sides of the crown. Crown perforations are mostly laterally placed or furcation involved. Okay, and what is the cause of access cavity perforation? It can be failure to identify the angle of the crown to the root and the angle of the tooth in the dental arch. It is most commonly seen in maxillary lateral incisors and mandibular first premolars. Now suppose a perforation has occurred. If the perforation has occurred, there would be bleeding in the canal and the patient may experience severe pain. Even after anesthesia, the patient can have pain. And when we are recognizing, we have to see whether the perforation is above the PDL attachment or into the PDL. We have to see that. Okay. So the presence of leakage into the axis is an indication of an accidental perforation into the PDL. And bleeding into the axis cavity is often the first indication of the perforation. There are other methods also of recognition of a perforation. It can be bleeding, it can be sudden pain, leakage of the material. Apex locator can show the perforation site. It can be seen by a radiograph, it can be seen by a paper point. If we are dipping a paper point into the canal and it is coming all red and moist every time, every now and then that is a perforation. And it can be confirmed by a radiograph only. That is the gold standard for it. We can see, we can appreciate all of the images here on the right hand side about the recognition methods. These are the different perforation repair materials that have been used since ancient times to cover the perforations. Amalgam was used earlier, but now it is not used. It can be super EPA, glass ionomer cements, GP, tricalcium phosphates, IRM, MTA, biodentine, and many more. Among them, MTA and biodentine are gold standard for the perforation repair because of their regenerative properties and the bioceramic nature. Now, how can we prevent the perforation from occurring? Prevention is by proper alignment of the burr with the long axis of the tooth. We have to see where the root canal anatomy is and where is the orifice of the canal. And we have to align the burr accordingly. Burr penetration for both depth and angulation can be confirmed with radiograph. Knowledge about the morphology is a must and adequate access preparation has to be done. Moving on to instrumentation related mishaps. So first and most common endodontic mishap that can occur during instrumentation is ledge formation. What is a ledge? It is an artificially created irregularity on the surface of a root canal wall that prevents the placement of instruments to the apex of an otherwise patent canal. Or it can be a deviation from the original canal curvature without communication with the PTL, resulting in a procedural error. This is termed as ledge formation. This is given in Journal of Endodontics, volume 33. We can see here in the images and the diagrams also of the ledge formation. Now there can be so many reasons for ledge formations. It can be caused by inadequate access, due to large instrumentation out of sequence, due to straight or inflexible or too large instruments in curved canals, insertion of instruments short of working length, unsuspected aberrations in canal anatomy, incorrect assessment of the root canal direction, forcing and driving the instrument into the canal, and complete loss of control of the instrument if the endodontic treatment is attempted via a proximal surface cavity or through a proximal restoration. Rotating the file at the working length, inadequate irrigation or lubrication during instrumentation, over relying on the gelatin agents, attempting to retrieve the broken instruments, removing of the root filling materials, attempting to prepare calcified root canals are among the few. How can all this be recognized? It can be recognized by loss of tactile sensation at the tip of the instruments when we are doing instrumentation. There can be a loose filling instead of binding at the apex. It can be when instrument is no longer able to reach its estimated working length. When in doubt of a radiograph has to be taken to confirm that is there a ledge formation or not. It can be treated by choosing a very small number of file using number 10 or 15 number of file and negotiating the ledge. It can be also done by a small bend at the tip of the instrument. We can make a J-shaped slight bend at the tip of the instrument, and then we can make a purchase point and we can penetrate the file carefully into the canal. Once the tip of the file is apical to the ledge, it is moved just in and out of the motion. We have to give ultra short push and pull movements. When the file moves freely, it may be turned clockwise, not before that. Then, when the ledge can be predictable, then efforts are directed towards establishing the apical patency with a number 10 file. Then, gently we pass the tapered 10 file 1 mm through the foramen, ensuring it that the diameter is at least 0.12 mm and makes the way for the 15th number file. Sometimes what happens is the ledge cannot be bypassed. That condition we do cleaning, shaping, and we fill till the obstruction. But we have to inform the patient about the same. That is very important and very ethical. Alternate treatment processes can be hemisection or radicectomy, or there may be a need of extraction also. Prevention can be by accurate examination of the diagnostic radiographs, then awareness of the canal morphology, frequent recapitulation and irrigation process, passive step back and balance force techniques are the most common accepted techniques for this. Then pre-curving the instruments and not forcing the instrument. We can see a pre-curved file here in the diagram below also. Then using instruments with non-cutting tips so that we do not perforate the canal. Then using night eye files is a better option. Canal blockages are another mishaps. These blockages are obstructions in a previously patent canal system that prevents the access to the apical constriction or apical stop. It can be because of many reasons. It can be dentinal chips, packing, tissue debris, cotton pellets, restorative materials can be packed. If the tip of the instrument used is wider than the canal diameter, it can happen. Blockage is confirmed by taking radiographs, which may show that file is not reaching up to its established working length. Treatment is when a blockage occurs, place a small amount of EDTA lubricant on the fine instrument. Use a gentle watch bending motion along with copious irrigation in between to remove the dentinal chips and tissue debris. Also, if this does not solve the problem, endosonics may be used to dislodge the dentinal chips by the action of acoustic streaming. Whatever happens, do not force the instrument into the blockage as it may further pack the dental debris and worsen the condition.